start with the
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome back. All right, welcome to the February 14, 2024 Valentine's Day regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and also accessible by Zoom. I ask that you please mute your system until such a time you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing.
Okay. Director Epen?
Present.
Director Wallace? Director Nicholson?
Present.
Director Yee?
Present.
Director Stewart?
Present. All communications. Members of the public are invited to speak during all communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Done? Cheryl, are there any written communications?
There are no written communications.
Then we'll move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion under either a member of the board or a member of the public request to remove the agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading for the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No. Does any member of the public want to remove an agenda item from the consent calendar? No. So may I have a motion to approve the consent calendar items A to D?
I move that the Board of Directors approve consent calendar items A through D.
Second.
Director Epen?
Aye.
Director Wallace? Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye. Now we'll go to the presentations. First one will be results of the audit, annual audit of 2023 by Pricewaterhouse Partners.
Yeah, I will introduce. It's our pleasure to have this evening Will Cobb. He's from PricewaterhouseCoopers, and he is a partner based in San Francisco. He has 25 years of experience serving clients primarily in the healthcare, nonprofit, and governmental industries. Will received his undergraduate and graduate degrees from Auburn University. He is a certified public accountant and a member of the American Institute of Certified Public Accountants. Will has significant technical accounting and financial reporting experience related to healthcare, governmental, and not-for-profit entities. He has extensive experience with bond offerings, affiliated foundation audits, and complex healthcare industry accounting and audit matters. Will have served as the district's external audit engagement partner since 2020. So thank you, Will, for joining us this evening and giving the results of our annual audit for fiscal year 2023.
Thank you. Pleased to meet with everyone this evening. And if it's okay, I'm going to share my screen with a presentation.
Right.
Okay. So this is the time when we are performing our required communications to the board as it relates to audit completion. We had met with the board earlier in the year and completed the planning communications, and this is the completion communication. So I'll walk through this, and if there are any questions or comments, please feel free to speak up. and I'll try to hit the key points as we work through this. I'm going to start on this highlight slide because I think it has a good summary overview. First of all, the main point is we have completed the financial statement audit for 2023 and have issued an unqualified or clean audit opinion for the district, and that's included in the district's financial statements there, the PwC audit report. There's actually within that audit report, there's 3 separate opinions for the opinion units of the district. We had discussed this earlier in the year. There's the district, the aggregate discretely presented component units, which are composed of the Warm Springs and Oncology joint ventures, as well as the fundraising foundation. Those in aggregate form an opinion. And then there's an opinion on the fiduciary funds, which are the OPEB and pension trust funds. So clean audit opinion, which is the opinion that you'd like. And then just as a reminder to the board, we also have another deliverable that we perform. It's actually due March 31st, which relates to the federal funding, COVID relief money, if you will, that the district received. It's a grant and contracts compliance audit, and we will complete that. And certainly, if there's any significant issues associated with that, we would let the board know about that. In terms of audit findings, relatively clean. There are no uncorrected misstatements identified for 2023. Management self-identified one prior year footnote classification matter, which I'll go through in a little bit more detail later in this presentation. But it was of a de minimis nature. It was clearly not material in the view of management, and we concurred with that view. And so that item was corrected. That prior year item was corrected in the current year financial statement filing. We had one control matter to report to the board, which is referred to as a significant deficiency, which means it warrants the attention of those charged with governance. And this relates to really the lack of evidence of supervisory review for account reconciliations and certain of the business processes that took place during the course of the year. As the board is aware, there has been some turnover within kind of the finance accounting function over the past year. And due to that turnover, some of the processes were not maintained in terms of the formality of the processes. So although management asserted that these interim account reconciliations had been reviewed by an independent supervisor, they were not in some cases able to provide evidence of that review. And because the formal documentation evidencing the segregation of duties is so fundamental to a system of accounting controls, we felt that this warranted the attention of the board. It's noted that the June 30, 2023 reconciliations were completed and were reviewed, and that supervisory review did exist. And so I think a lot of the changes that have happened in terms of staffing and with new people coming on board and getting a handle on things, I think prospectively the changes, as we understand it, have already been made to address this particular item. And just one last point I want to be clear about on this. There were no errors that we identified associated with this matter. It's merely that lack of documentation evidencing that review. And I guess I'll just pause for a second to see if management or anyone has any comments on this. Okay.
What do you consider evidence of review?
Yeah, so it can take various forms, but ordinarily, what it would be is literally a sign off, a signature on a reconciliation form would be kind of the standard documentation. Sometimes that can be accomplished online. And so what seemed to have transpired were there were these meetings with the reviewer and the preparer where they would go through these documents, but there was no sign off that process completed. So it made it difficult to demonstrate that supervisory review had occurred. Does that make sense?
Thank you.
Okay. And we have a point here on the right side of the screen. Just as a result of the control matter, we did increase our testing, particularly substantive testing, so that transactional testing, the tests of details. Ordinarily, that's where we get most of our audit comfort anyway, is through testing of transactions rather than testing of controls, because it's just more efficient for us to get our audit comfort that way. The district is not a publicly traded company under Sarbanes-Oxley rules that would require an internal control opinion. So didn't have a significant impact, but it is a required communication. And then on the independence area, happy to report there were no independence issues associated with our ability to, maintain that external audit independence from the district. So no issues to report there. I'm just going to briefly walk through risks and results in some of the significant areas. We had outlined one item here as a significant risk, which is the management override of controls. As I had mentioned earlier in the year, this is a standard significant risk in all financial statement audits that obligates us to perform certain procedures associated with the risk of fraud. So it should not alarm the board that this has been identified as a significant risk. It's very standard. We perform a number of procedures in evaluating those risks and did not identify any financial statement risks associated with the management override of controls. The other significant risk is very much an industry standard significant risk in the healthcare industry. And that's with regard to patient revenues and specifically the valuation of patient accounts receivable, just due to the inherent complexities in the healthcare industries with third-party payers, governmental payers, and the interaction with the patient and the nature and timing of those payments is just an inherently complex, subjective, judgmental area of estimation. So again, I don't think this should alarm or concern members of the board. This is just the nature of the healthcare industry, and management puts a lot of effort and focus in this area. And with the new oncology joint venture operating, that was a significant risk in that area as well. We performed, various procedures, which includes subsequent cash collections evaluations. We have the benefit of hindsight in order to see how much cash comes in after fiscal year end and compare that to the reserves and values that had been recorded in the financial statements and found them to be reasonably stated. It is a significant estimate, as I mentioned. This just has a little bit more detail about management's process and look-back analysis and the historical cash collections analysis that we utilize. And again, found those receivables or unpaid revenue amounts to be reasonably stated. A couple other areas that are areas of estimate, not considered to be significant risks because they're fairly standard, but they do require outside expertise, is in the area of actuarial valuations for the district's pension and post-employment medical benefit plans. So the district utilizes outside experts to evaluate certain of the assumptions and assist the district essentially in performing the valuations and recording the amounts in the financial statements and the various footnote disclosures and required supplementary information surrounding pension and OPEB. We, in turn, also have actuaries that assist us in evaluating those assumptions and values, and we found them to be reasonably stated, as well as the disclosures and presentation in the financial statements to be appropriate. There was one new accounting standard, not material to the district, but it is displayed in the financial statement footnotes, the impact of that standard, which is the GASB statement number 96, subscription-based information technology arrangements, or SPIDAs, which requires governmental organizations to essentially put on balance sheet some of these obligations and the related, right of use assets for those IT arrangements, sometimes referred to as cloud computing arrangements. But again, it was not material, and the impact on all the related financial statement line items is discreetly presented in the financial statement footnotes. So you do have the ability to look at that if you would like to see some of those detailed impacts. But again, immaterial overall to the financial statements. Other required communications, I'm not going to read these word for word, but these are, for the most part, very standard. The required communications that you would want to hear. We did not identify any instances of fraud. There were no disagreements with management. We certainly received the full cooperation of management in the performance of the audit. Again, very standard. There is one I referred to earlier, which I did want to just highlight for a second down at the bottom of this slide on the identified misstatements. Management did bring to our attention a presentation classification matter with respect to the what's referred to as the blended component unit footnote. This is where the information for the hospital and the information for DevCo are presented separate and apart from each other, and then they consolidate, and there's a consolidated total. And essentially, there was a misclassification within the net position line items for those two entities that, again, eliminates upon consolidation, but it is a required disclosure. And there was, as listed here, a $15.7 million classification difference, again, in the prior year number, which was corrected in the current year presentation. So overall, fairly immaterial in the context of the financial statements taken as a whole. We had included just in the appendices some written material, written correspondence, for example, the management representation letter that we received and some other materials, but I'm not going to go through that in detail at this time. And at this point, that concludes the presentation that we have, and we'd love to address any questions or comments that you have.
Thank you. Any questions?
It's another good year.
Yeah.
I'm sure it was a lot of work.
It was a lot of work, and I do just want to thank Will, you and your team for all the work that you did, and really the collaboration, and want to just say thank you to Tom and the team in finance. It really together, I know we had a lot to do with all the different components and that, but I really felt like there was a lot of good collaboration and communication. So I thank you, Will, and I thank you, Tom, in terms of both of your teams and all the hard work. So thank you. Yeah.
Thank you. Yeah, concur with those remarks and agree. A lot of effort on the part of the finance team, and thank you, Kimberly and Tom, for providing us with full access to books and records.
All right. Thanks for the clean bill of health.
Yeah.
Thank you, Will.
Okay. Thanks, everyone.
Thank you.
The next presentation.
Did we take action on this now? Yeah.
That's what I was going to say. That was my next question.
The little thing. Can you do the item A right now?
Sure, thank you.
It's on the audit.
Mr. President, I move that the Board of Directors approve the annual audit report for fiscal year 2023 as presented.
Second?
Director, I'll take roll.
Aye.
Director Epen.
Aye.
Director Wallace. Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart.
Aye.
Great.
Mhm.
Great.
So the next presentation is on cardiothoracic surgery and structural heart program at Washington Hospital by Dr. Amin Begi and Dr. Harsh Agrawal.
Yeah, and I will introduce both of them. I'd like to start with Dr. Ramin Beghi. He's concurrently joined UCSF School of Medicine faculty in the Division of Adult Cardiothoracic Surgery and assumed the position of Medical Director of Cardiothoracic Surgery at Washington since May of 2016. Dr. Beghi has practiced cardiac, thoracic, and vascular surgery for the past 22 years at UCLA, Stanford, and UCSF medical centers and has been practicing the entire scope of his experience and expertise. He has served as the Director of Thoracic Aortic Aneurysms at UCLA and the Surgical Director of Lung and Heart-Lung Transplantation at Stanford University Medical Center and Lucile Packard Children's Hospital. As Medical Director, Dr. Beghi assisted with the development of a full range of cardiothoracic services locally to meet the needs of our community. To further that goal, Washington Hospital has a strategic relationship with UCSF Health and UCSF Benioff Children's Hospital.
I think they're just making sure Dr. Beghi.
Oh, okay, they're making sure he's on. All right, then let me go and let me just also introduce Dr. Agarwal, and we can go from there. Dr. Agarwal started working at Washington Hospital in 2021 as part of the TAVR procedure team from UCSF Health. He quickly built relationships with our local cardiologists and began to help them manage their patients' structural heart disease and to perform procedures such as mitral clips, Watchman device insertions, and other complex cases in the cath lab at UCSF. And we'll hear more about what all those mean this evening. He has served as the Associate Cardiology Fellowship Director at UCSF, as well as the Assistant Professor in Structural Interventional Cardiology. He continues to practice interventional cardiology and structural heart at California Pacific Medical Center, while he builds our structural heart program at Washington. Dr. Agarwal has recently joined the cardiology group at Washington Township Medical Foundation and has accepted the position of Medical Director of the Structural Heart Program. We've been able to, they were both on. All right, so Dr. Beghi, I think we're going to start with you.
Thank you so much, Ms. Hart. Thank you, ladies and gentlemen, for the invitation to be here. I'm very happy to be here on the Valentine's Day. Happy Valentine's Day. It's a good day to talk.
Thank you for being.
Thank you, about broken hearts and mending them. So I will just take a few. With that introduction, I was wondering if I could advance to this next slide, please. Thank you. So just an overview to the board members. You know, the scope of cardiothoracic surgery has really expanded and has developed over the past 20 to 30 years. You know, from doing a complicated. Sorry, can you hear me okay?
Yes.
Yep.
Great. So from doing a complicated open chest operations to trying to do them minimally invasively with less exposure, thoracoscopically, small incisions on the sternum, to basically trying to combine our skills with our cardiology colleague and vascular surgery colleagues in trying to do the operations that are both expansive in scope and in treatment, emergent, urgent, elective, to also less exposure and less incision and less length of stay. So as a result, the three specialties, really, the cardiothoracic surgery, cardiology, and vascular surgery has merged to a point that we have a lot in common. If I could have the next slide, please. So for a long time, cardiac surgeons, we did a lot of training to treat valvular heart disease, mitral valve, aortic valve, and the operations were in general performed on cardiopulmonary bypass with an open chest. As we expanded our approach, we tried to do these operations through smaller incisions to be more comfortable for the patients and a faster recovery. Then the transcatheter technology advanced, and the cardiology colleagues, their area of expertise overlap with our area of operation. So we have worked with structural heart cardiologists closely to have basically the whole scope of practice that includes open heart operations for valvular heart disease, as well as transcatheter operations and transcatheter technologies that include replacing aortic valve or repairing mitral valve and so on. Atrial fibrillation, on the other hand, the scope of cardiology and electrophysiology for the long time. But then we also have learned that in collaboration with our cardiology colleagues, we can provide less invasive Mays procedures, closure of the left atrial appendage from the outside, or treat the left atrial appendage from the inside, or the atrial fibrillation from within the heart, or externally So on those areas, we also have overlap. With aortic aneurysms and dissections, we've been doing open operations for a long time, and we advanced our techniques of the spinal cord protection, protection of a distal perfusion of the aorta. And then with the advent of endovascular procedures, now we can do those operations without any open exposure. And in those areas, we overlap with our vascular surgery colleagues and at some level with our cardiology colleagues. Coronary disease has been the main treatment of coronary disease has been the mainstay of our practice. And now with the work with our interventional cardiology colleagues, we can treat severe coronary disease in high-risk patients in a hybrid manner or transcatheter manner, and endoluminal manner, also operate on them if it's necessary. In congenital heart, adults with congenital heart disease, for a long time, we've been treating septal defects and abnormalities of the aorta and various structures. But then our structural heart cardiologists are able to treat a variety of those conditions without opening a patient's chest or without going on a heart-lung machine. And the last thing is the transcatheter aortic valve for aortic stenosis. We did that operation well, even in octogenarians and in high-risk patients. But with the advent of transcatheter aortic valve, now we are able to treat the patients who are prohibitive risk, and then subsequently patients who are intermediate risk, and then even recently patients who are on low risk with transcatheter technologies that patients can stay in the hospital shorter period of time and then return to home and work closely. So that's why the addition of Dr. Agrawal to our medical staff is so important, because we have been collaborating and working with him on all of these areas at UCSF for many years. And then he has agreed to be on the medical staff at Washington Hospital. And I'm hoping the same as we are doing with the TAVR procedures, we can also expand to other areas. I've known Dr. Agrawal since 2018 when he came to UCSF as a fellow, and then he stayed on when after Dr. Mahadevan departure to be the go-to person for all these particular high risk and intermediate risk and all sorts of procedures. And I'm just very happy and delighted that he has decided to stay at Washington Hospital and help us develop these programs further. With that, I just hand over the slides to Dr. Agrawal, and I'll be happy to stay on and answer questions.
Dr. Big, you're too kind. Thank you so much. Can you hear me properly?
Yes, sir.
Sorry. No, thank you so much, Dr. Biggie. He's been, my mentor and inspiration along with, our staff. I'm Harsh Agrawal. I'm the cardiologist. Sorry, I'm at home with my kids. If you hear kids in the background, I'm sorry. It's a small space in San Francisco. So, but thank you for the board, Kimberly, Larry, Ed, Linda, Melissa, Dr. Biggie, Dr. Lee, everybody for having me and making this happen. I'm Jason, of course, our medical director, for having me here. Next slide. But so what is TAVR? I want to say, that TAVR is one of the revolutionary technologies that Dr. Biggie, I, and Dr. Lee do. Dr. Biggie, obviously, he does it in all three ways: minimally invasive, invasively, and through the groin. So this is something that we can offer our patients in the Fremont, the Tri-City area, who have very high surgical risk, don't want to undergo an open heart operation through the groin, most 90% of the time, and replace a valve, which has revolutionized the world of valve replacement. This is because it's one of the most common heart valve disease in the United States and now slowly in the world. To be honest, between me and Dr. Biggie, we have done 32-year-olds who have very high risk and 104-year-old gentlemen. So you can imagine the range that we can treat with this procedure appropriately. Next slide, please. So it's used for a valve disorder. People who have shortness of breath or dizzy, lightheaded, generally come to us. Just to give a perspective, aortic stenosis is more deadly than cancer. People who do not get treated have like 50% mortality at 1 or 2 years when they're symptomatic. Like the heart can fail, they get dizzy, lightheaded, pass out. It's a very deadly disease and a very curable disease as well. So that's something I want to tell our patients. And, we have nanogenarians, octogenarians who are in this age range that they used to go to. There are 7 other valve programs now in this area, and we are one of them as an independent valve program, which I'm very proud of. So we can offer that at Washington Hospital. So next slide, please. So, there's no comparison, that 2 things are different, but Dr. Beghi can speak to this more, but, a transcatheter valve replacement in a nanogenarian or octogenarian or in a high-risk patient, we can do it without general anesthesia. We don't have to put them on bypass machine. And it's a pretty, I wouldn't say simple, but faster procedure because so well planned. SAVR is a very more intricate procedure, as Dr. Beghi can tell me. I'm not going to speak to that, but it's very intricate. Is done very properly. It takes a little bit more time, and it's the gold standard. I'm not going to say SAVR is not right, but there are some patients who cannot tolerate this amount of heart-lung bypass or general anesthesia, or who don't want it. So TAVR at this point is one of the leading, valve replacement procedures in the world, not just in the USA. Next slide, please. So we started our program in 2021. We had 170 referrals, which is pretty good for our Tri-City area. We've done 76 procedures, and our mortality rate is less than 1%, which is actually better than the national average, which me, Dr. Beghi, Dr. Lee, Linda, everybody is very proud of. I did most of them with Dr. Mahadevan initially, and he left, so I've been doing them. We have a really robust conference about this. We talk about each patient individually. We do a lot of testing to make sure they're a good candidate. We can offer them a good quality of life and higher, what we're offering them. And if it suits them, we have a lot of patients who have been turned down because we didn't think they were a good candidate. So it's a very comprehensive, patient-centered approach. It's not my decision or Dr. Beghi's decision or Dr. Lee's decision. It's all of us together with the patient in the center. So that's what I'm proud of. Okay, next slide, please. So as you can see, this is very good. I was at UCSF, and Dr. Beghi can tell. I used to do all the high-risk cases still, and our mortality rate was higher there. But we have done. So we did our first valve in valve. So a person who had 2 valves replacement already, we did a 3rd valve, and this was the first in the Bay Area, actually at Washington Hospital recently. And Dr. Beghi was a part of it. So our complication rate is very good, partly because we choose our patients carefully, partly because, we're good. I'm sorry to say that. And then, so we are still, our pacemaker rate is high, and we are still working on that. But, for the Tri-City area with the population, the Indian, Chinese, American population, I think this is a very valuable program that we are offering, because all these patients 4 years ago used to come to UCSF when I was a fellow and a new attending. And Dr. Beghi and Dr. Lee know that we used to do them, and we could not offer this at Washington Hospital, given that such a high volume, such high acuity, with opening a trauma center. I think it's much in need that we can offer some of these programs at our hospital. Next slide, please. So, I'm not going to go into the intricacies of the program, but, it's a very, very close collaboration between CT surgery, Dr. Beghi and Dr. Lee and me. We do it together. We need 2 people to do it. It cannot be done by one person. We do need a hybrid OR, which I know it's underway at Washington Hospital, which I'm very excited about. And Linda and Melissa have helped us do that. And once we do this, we are seeing more and more people being referred to our program because of our success and good outcomes, which speaks a lot of volumes about our, like the way we do it and we approach this disease. Next slide, please. So just to give an overview, What is structural heart disease? It's all the valves. Dr. Biggie just mentioned all those seven conditions. I do all of them. If I actually submitted my credentialing to Dr. Romano recently, and he's like, we don't do this here. So slowly we're gonna bring all of those things here. But all the heart valves, all the complex PCIs, like Dr. Biggie does, as as an open heart surgeon, we slowly started to evolve them as an interventional cardiologist. I want to call Dr. Biggie a hybrid surgeon. He's a cardiologist too because he does this with me. So next slide, please. Sorry, I have a little cough. So TAVR is the standard of care for people who are above, I would say, 80 years old, 75 to 80 years old. And then next slide, please. I'm going to talk about something that we're trying to do for our Washington Hospital folks, something called MitraClip. That's the next valve that we're going to repair. It's a leaky valve, and there is a transcatheter like the TAVR. There's no open heart surgery for people who are about say 70, and who are high risk for open heart surgery. We can do that through the groin and replace the valve. I was the highest volume operator in the Bay Area for the last 2 years. And same thing, something called a Watchman is to prevent strokes in patients who have heart failure and atrial fibrillation. So given our trauma center is opening, these are the two things that we're gonna be very, very excited about in the next year. Next slide, please. So yeah, we are gonna be a comprehensive structural heart program with the CT surgeons. We already have TAVR. I think Larry, Kim, and everybody else Ed and Jason have apparently pushed a Watchman program. So we're going to be having a Watchman program that's to prevent strokes in people who have high risk of heart disease. And the third part is the MitraClip. That's the second valve. And I'm hoping in the next 5 years, I'm looking at this as a comprehensive heart valve program at Washington Hospital. Next slide, please. So, we have very strong partnership. Dr. Biggie and I think I think I text him more than his family at this point, but it is what it is. Linda, Melissa, Jason, everybody has been very supportive. We have a community outreach, we have an outreach program. And if you imagine, there are 7 centers around us doing this. There is UCSF, there is El Camino, Stanford, obviously, Sutter Health. There are 3 programs by Sutter Health, Mills, Oakland, as well as they're trying to do a program down south. You have Sonoma County. So we are competing with a lot of people, but the Washington Hospital initially, we used to send out patients, but now we're going to keep our patients who we can appropriately and offer complex PCIs, TAVRs, hopefully Watchmans and MitraClips, and refer out. We don't want to be a heart transplant center, but we want to be everything else. So, and I think we can be, and we are already doing that with complex PCIs, as Dr. Biggie knows. We've done a bunch of them recently. Next slide, please. And quickly about Watchman, I don't want to go into intricacies what it is, but people who have atrial fibrillation, which is one of the commonest heart arrhythmia disorders in people who are above 65, and they have the stroke risk is above 2% if you're above 65 years old. And if you cannot tolerate blood thinners because you're active, if you want to go mountain climbing, if you want to go bicycling, if you fall, or if you have bleeding issues, we can close with a small device. There have been about 1 million of them done now in the world, and it reduces your stroke risk about by 50%, which is amazing. And we can do this less than like 30 minutes. And you don't have to take a blood thinner for the rest of your life, which is huge for a lot of patients. Next slide, please. So this is the Washington Hospital population. You can see 50%, 45% reduction when they develop AFib, 5,000 patients, 11,000 claims, So we have a huge catchment area where we can help people not be on these. Uh, if I can be crass, Coumadin is rat poison, right? They were used to kill rats in the 60s and 70s. Dr. Biggie, maybe you can correct me. So that's where we were giving patients to prevent strokes. We have newer drugs now, but they still have a higher risk of bleeding. So if you can help people by doing a procedure which is very low risk and low complication, and they can just take an aspirin a day, I think that's a huge win for our patients. Next slide, please. So this is my passion. I'm very passionate about Dr. Biggie is an expert in mitral valve repairs, but mitral valve is the other valve of the heart instead of the other. This is a leaky valve. There are a lot of patients who cannot get open heart surgery, which is the gold standard. I would never go against it, but there are a lot of patients that I treated, and I still treat. Washington Hospital had about 20 patients that I took to CPMC and UCSF last year, but I did this procedure where I can go in from the groin. We can bring the mitral valve together like a butterfly clip. If you can think about it, it takes about an hour and patient goes home the next day. It's not the gold standard, but it is an option for a lot of patients who are very high risk for surgery. Next slide, please. These are the references. I will happy to take any questions. I know I went a little fast. I didn't want to go into the medical jargon. I know the literature by heart. I can recite some of these articles, but I'll be happy to take some questions, please.
I was wondering if I could just interject for 1 second. So all the programs that Dr. Agrawal is describing, not only will be a good service for our patients so we can have low-risk operations offered to them, it actually does increase our overall open heart cardiac surgery volume as well. If they know we can intervene on total coronary occlusions that are totally occluded, and then we also get patients in that group that would be benefit from coronary bypass grafting the standard way, maximum arterial grafts that we are also added. Atrial fibrillation also brings in a number of patients who have coronary artery disease or valvular heart disease that may be treated either with open surgical procedures or structural heart procedures, like Dr. Agrawal said, through a small venous access, repairing the valve. There are patients who have heart failure and mitral valve disease that are not necessarily good candidates for surgical repair, but there would be very good candidates for transcatheter clips that it can reduce the degree of mitral regurgitation and allow them to have a better quality of life and improve overall function and stability. So these programs, they don't necessarily negate each other. They tend to be synergistic and support each other. I think having a heart surgery program supports the structural heart program, and structural heart program supports the heart surgery program. And the same with vascular surgery. As our three specialties are merging, it brings us to last court that actually is a very good idea to have a cardiovascular institute that looks at totality of cardiovascular disease from the cardiology, cardiac surgery, and vascular surgery perspective. I'll be happy to answer any questions as well.
No, I 100% agree with Dr. Biggie, because this is like an aura effect or, domino effect where you get structural heart or, cardiac surgery patients who might not be benefiting from cardiac surgery, but they can go to, structural heart or vascular surgery. It's a big domino effect in that sense. And, not every patient is suited. And that's what, it comes down to, like, what suits you. We have to tailor our needs to the patient and not just be like, this is what works for you. Doesn't matter if you're laying on a deathbed, we're going to just do this. So it has to be tailored to each patient. And that's what I really, really believe in. There is, for me, there's no cost of life. I know there's everything financial. We have to think of that. But when it's your loved one, if I ask you a question like, what does your loved one cost? Give me an answer. I'm pretty sure there's none. So, yeah.
I have a couple of questions. When and where was this TAVR first done?
The TAVR were first done in France, Doctor and Columbia Hospital, 20 years ago. the guy, he's a French guy, he developed it, and think people thought he was crazy. And I actually met him, and they said, this is never going to work. And then Marty Leon at Columbia, and I think I was in med school at that time, but then he said, we're going to try it. And this is 25 years ago, 22 years ago. And now TAVR is actually a class 1 indication in anyone between 65 and anyone above 65 years old to have a medical decision-making capacity. So, yeah.
And is there any shelf life on this TAVR valves that you place?
I would say 10 years, like the surgical valves, Dr. Beghi. But what do you say? It's made of the same tissue as the surgical valve. So
the longevity of the valves, we don't have an extended long data on them yet, but I think in the future we will. The same as the surgical valve, that the transcatheter aortic valves are also advancing. The anti-calcification mechanism, the technology is advancing and getting better. So one scenario that we see in our younger patients, perhaps younger than the age of 70 or 75, who are good risk candidates, they may get a surgical aortic valve replacement. And then perhaps 15 years later, the next procedure would be a valve-in-valve transcatheter aortic valve. And then they can even potentially have another valve in the future. But the technology is advancing. I think it may be even more durable for younger patients. And as of now, the discussion with our patient is a little bit reversed. We actually discussed a transcatheter aortic valve first. And if we think they're younger, they have a bicuspid aortic valve, they have concomitant coronary disease, aneurysm of the aorta, for whatever reason, we think that the aortic valve alone would not be sufficient, then we offer them a surgical procedure. Otherwise, transcatheter aortic valve, even our younger patients, seems to be okay. We just the other day, Dr. Agrawal and myself, we did a valve-in-valve, which was a valve-in-valve-in-valve. That means there was a surgical aortic valve, that was a TAVR in it, and then subsequently we put another TAVR inside the valve. So eventually, if they get really, really small, it would be a problem, but the two valves are the same size, so we can treat multiple valves in the same patients.
Yeah, and that was the first in the Bay Area, I think, Dr. Beghi. I don't think I've ever done that before. Yeah, no, thank you. But yeah, the shelf life, if you look at the rat model, it's 20 years. It's like the surgical valve, because the tissue around the valve is the pericardial bovine tissue, which is the same as any of the surgical valves, except the metallic valves. Obviously, metallic valves are supposed to last lifetime, but then you have to be on Coumadin forever, which is, at this day and age, younger patients, they want to be active. They don't, they want to fall down, they're going to get hurt. And if you're on Coumadin, it's a big risk. So, yeah.
No, just a comment. I think the patients of the district are very fortunate to have the cardiovascular surgeons and the structural heart specialists that we have here at the hospital, so that we can actually take care of them here in our own backyard, but using the most advanced techniques. So thank you, Dr. Beghi. Thank you, Dr. Agrawal.
Yep. Thank you.
Thank you.
Thank you, guys.
No, thank you, sir. No, I'm
you,
very
Dr.
excited to be here. It's so exciting.
There couldn't have been a better day to shop on 15 hearts than Valentine's Day.
Mm-hmm.
Thank you.
Okay, so we'll log out with your permission. Thank you for the invitation.
Thank you.
Thank you.
Thank you, everyone. I appreciate the invitation. Thank you.
Bye.
More to the construction update.
Ed is going to give, I think, one of the last presentations on our patient bridge in terms of, we're getting close, right, Ed?
That's correct.
Yes.
So our targeted completion date was January, I think, 17th. There's still a few odds and ends that are being done, but as I'm about to show you, for all practical purposes, it's done. There's just some sort of fine-tuning that's being done, and they're demobilizing off the site by and large. Okay, I'll try to fly through these. This is a representative from the last 2 months, December and January. So if we could go to the next slide, please. Okay, this is showing you work that was done on the fire escape or the fire route escape from the main hospital and the 1958 building exit near materials management. This is now the door that is the escape. Next slide, please. This shows you, we're going to show you this multiple times here tonight, but this is then showing you the work that's going on with the bridge to complete this space. You can see the tie-in to the CJR corridor. We've got two different materials we're trying to match here to create this exit. Next slide, please. This gives you a shot on the other side of the bridge that's closest to the hospital, and they're just giving you a few different shots of the expansion joint between the bridge and the existing hospital. And you can see it's in a couple of locations down low, and then if you look up where the scaffold is, there's more expansion joint there. Next slide, please. This is showing you the cab. So the cab is going to take the seismic movement of the Morris Hyman Critical Care Pavilion. So that we're going to show you a few more slides on this so you get a better idea of how this is going to work. Next slide, please. This gives you one shot of what the bridge is looking like inside. It's you kind of lose the dimensions, but that's an 8-foot corridor going between the buildings. Next slide, please. This is giving you a shot down the hallway where it's showing you some of the steel going in, and then more of a finished look. And this is on the Morris Hyman side, and this has actually been finished. We'll show you the final product here in a minute. Next slide, please. This is just showing you the Mecco shades that are covering the windows of this corridor. So those Mecco shades are actually going to be timed so as the sun is moving across, from morning to evening, that these will automatically come down and provide some temperature help and keep the direct sun from going into patients' eyes as they go down this corridor. Next slide, please. This is just the connecting or the receiving corridor on the Morris Hyman side. So you can see that this is getting completed, the studs on one side and then your completed drywall on the other. Next slide, please. This is just a shot of the expansion joint. Again, this is on the Morris Hyman side. Next slide, please. This gives you a shot of some of the work that's starting to get completed of the underside of the bridge. And we've shown you the sprinklers in past slides. You can see then the finished quote unquote ceiling that's going in place. Next slide, please. That just gives you a look again. You can see the cab on the left-hand side, and that's getting patched or closed up here. Okay, next slide, please. So there you see the cab itself is closed up with the metal panels, but the part of it that's attached to Morris Hyman is not completed yet here on this picture. Next slide, please. This shows you the other side closest to Morris Hyman, again, the cab. Next, and you can see down at the other end, that's not completed. Here you've got the cab closest to Morris Hyman completed, but the hospital side not yet complete. Next slide, please. Okay, so there you've got what we have looking more and more like a finished product, though the cab is still incomplete. Next slide, please. Okay, here's then the later photos showing that you're getting the staircase and the total exit getting finished off here. Just for FYI, this is one of the fine-tuned things. The stairs came in, and the bottom step of the stairs has to be flush to the concrete. So that's one of the things that we're cleaning up, and the contractor is taking care of that. Next slide, please. Same area you can see here. It's on the right-hand side. You can see more of the finished product, and you can also see expansion joint, that gray seal along the side of the column there. That's been completed on the right-hand side and was still going in place on the left. Next slide, please. another shot, probably a better shot of the expansion joint going in. Next slide. Here you're seeing a finished product of the ceiling, the underside of the bridge. So everything's in place, and that's now the finished product. Next slide, please. This gives you a little bit of a feel for the feel of the look of the inside of the bridge. You can see they're putting in ceiling tile in the left, and then that's the finished product with the lights on the right-hand side. Next slide, please. Also gives you the feel of the finish. This is, I believe, on the hospital side looking towards Morris Hyman. Next slide, please. That's just a completed compartment or the hallway on the on the Morris Hyman side. Next slide, please. This gives you a look at, the work area and how we're finishing off the landscape so that we've got an attractive feature there. There are more plants that are going into the area. Next slide, please. Okay, now this is the cab. So you can see that the Morris Hyman side, we had the removed panels to get into the building, and then you can see what the finished product looks like once we've got both the side of Morris Hyman buckled up, but then we've got these plates that go around the cab that are the parts that will move in the event of an earthquake. So those solid panels closest to the building will actually, if the Morris Hyman moves, that those will open up or do sort of a flyaway from the bridge side. And they're on both sides of the cab, and then they're on the undersides because the building can move back and forth, up and down, and in and out. And so that whole thing has to be able to move with the Hyman building movement. Next slide, please. Again, gives you a look at the finished product on the other side of the bridge. Next slide, please. Okay, this is a little bit difficult to explain, but this is inside the cab, and this is giving you a feel, the beginning of the feel of what's been placed in here. If you look at the flooring on the left-hand side of the picture, on the flooring, you can see a break in the plate, and so this is the plate that actually it's hard to visualize this, but one plate can run over the other. If the building moves, the plate that's closest to you will move over the top of the smaller plate closest to the building, and so you get that movement that's going back and forth in and out of Morris Hyman. The other thing that this does, and it's even if you watch a video of it, it's kind of hard to understand. It will also move left and right of its current position if that's the way the building moves as well. So that whole plate can move in basically all directions. Next slide, please. This is also this is a wall that also you can see the flooring piece down below, and then this wall will also have some movement potential there if in the event of an earthquake. Next slide. So you get a feel for sort of the finished look, and you can see the plates that are underneath there that are the parts that will move over on top of each other in the event of a quake. Next slide. So now you're starting to get a feel for a finished product as we finish off sealing up that side of the cab. Next slide. Next slide. Finished on the other side. Next slide. Other side of the bridge, same thing. Finish. Final slide, I think it is next. So hopefully you remember the artist rendering that we saw at the beginning of the presentation. This is your final product. Hopefully it looks the same as the idea when we started. And you'll see that the bridge actually matches pretty nicely with the CJR and the Hyman Pavilion. So it's all a pretty seamless finished product. And that's it. Any other questions I can take on this bridge project? We have still as of today, we still have a good amount of contingency left. So we are going to stay under budget. As we've talked in the past, we will continue to get invoices on this for probably the next year, but our contingency looks to be substantial, and with all our projections, it looks like we are still going to finish this project under budget. And obviously, we didn't hit our January 17th date, but for all practical purposes, it's completed, and it'll be final done by the end of the month.
How many total feet from building to building, this bridge?
I just answered this question for our EIR. I want to tell you it's 180 feet long.
Thank you. Yeah.
Yeah. So Ed, I'm trying to figure out, when the big one hits, do I want to be on the bridge or in Morris Hyman?
I had that same question.
Well, both of them are seismically safe. The bridge, as you might have, I didn't spend a lot of time on this, but you might have seen the crossing steel girders that I believe you'll be able to see through the windows, okay, and you can, I think, make them out here in this picture. So it's seismically safe, and it's a rigid structure. So it's built to basically hold in place and not move, but it's built to take the movement. And then if you're on the Morris Hyman side, you're in the most advanced seismic structure that we know of. So they're both built to code, and you should be safe in either one, and they should be either one of them should be standing, for everything we know, should be standing and functional post-quake.
Thank you. So they'll both be safe, but it'll be a little more exciting on the bridge.
Yes. Well, yeah, that's probably, you're going to feel it in either place. Yeah, in the building, it may be a little bit more jarring because that building is going to move, and it's going to move. It could move up to 3 feet. So, that's either you shouldn't feel as much, I guess, in the bridge, but you will definitely feel the quake in either location.
I'm not going to answer it.
Well, it's a wonderful investment for our community.
Thank you. Wow.
You're welcome. And as we've discussed, as we've tried to do each of these projects, we anticipated the master plan, and we did leave a section of the far side of the bridge, the side that you don't see directly here, for future connections with corridors and elevators as we have outlined in the master plan. So it's ready for, the build out as planned today.
All right, great. Thanks, Eddie.
Thank you.
Thank you, Ed.
Thanks, Sam.
Thank you.
Of the reports, next will be medical staff report by Mark Selleck.
Unmute.
Mark, you're muted.
Thank you. I was saying good evening and happy Valentine's Day. The aquablation program is going well. I did a Facebook Live presentation yesterday, which was recorded and is on the YouTube channel for the hospital. It's already getting some hits. I've had a few patients approach me either in the clinic today or through my chart messages that say that they saw it, that they're interested, and that want to talk to me about aquablation. So the word is out there, which is great. we had a lot of patients at the end of last year from pent-up demand, and it's kind of slowing to a regular steady state now. And I expect steady number of patients on a monthly basis. The leadership development program is ongoing. We had one a few weeks ago. I think I reported it at the last board meeting, and we are trying to find a time now that is can accommodate everybody's schedule for the next meeting for the current and future leaders. And then the final thing is I was part of a group of administrators and doctors that went down to Southern California last week for the Beta Heart Program training. And you'll hear more about that as that kicks off, but it's going to be starting soon. And that was a very helpful and informative program, I thought. Am I supposed to be doing the core measures at this meeting as well?
Nope.
No.
No. Okay. Good. I had it ready just in case. I didn't think so. Any questions?
Thanks, Mark.
Thanks, Mike.
Thank you very much.
Next, move on to the next leading report.
Yes, it's my pleasure to introduce Anita Bezai. She's the Director of Biomedical Engineering, and she is going to be presenting the lean report this evening. And just a little bit about Anita. She has been here for about a year now. And in 2011, Anita graduated with her master's degree in biomedical engineering from Wayne State University, Detroit. Anita has over 12 years of experience in biomedical engineering and is very passionate about improving patient care through technology while simultaneously striving toward innovation and cost efficiency. Anita's leadership experience in the biomedical engineering field has been diverse and encompassed various healthcare systems. She has led several departments in various hospitals within the Veterans Health Administration and integrated healthcare hospitals such as Brigham and Women's Hospital. Anita continues to be active in various engineering society, Society of Women's Engineering, Association for the Advancement of Medical Instrumentation, and American College of Clinical Engineering. While she is not working, she can be found pursuing her newly discovered passions of boxing and kickboxing. Don't mess with me. Well, welcome, Anita, to the board meeting, and I'm going to turn it over to you to do your presentation.
Thank you so much, and happy Valentine's to everybody. Thank you for the warm introduction. I'm very excited today to join you guys this board meeting today and share our lean initiatives for our digital huddle board and data analytics. Before I start, can you guys hear me okay?
Yes, we can hear you great.
Perfect. All right. So, and then you guys can see my slides. So, before I continue to dive in a little bit on our work and efforts for both of these initiatives, I'd like to quickly reiterate our mission and goal, our departmental mission and goal, which is ensuring safety and functionality of our medical equipment for all of our patients, our visitors, and of course, our hospital employees. And we do so continuously by providing and conducting, recurring testing, repairs, inspections, quality validations. We additionally, as a technical and clinical merging of that department, we provide, support and resource on the market research, selection, and implementation and deployment of new equipment or existing technology as well. Our department provides 24/7 service, 365 days a year. We do have a team, total team members, 6, including myself. Being that we are a small team, efficiency on our work is very critical and important. And same thing with optimization, it's very critical for us to improve and increase our optimization of our workflow and processes, as well as our communication. Streamlining our communication is essential, and we do so in all of our different variation of our work tasks, like corrective maintenance, basically our unscheduled or unplanned repairs or work, preventive maintenance, recurring inspections or planned work. We conduct the same, efforts and on our patient safety investigations and recalls or alerts. When I joined Washington Hospital healthcare system, one thing that as part of my first 90 days assessments, I noticed that our equipment inventory, basically our equipment or asset information database called AIMS, is an unreliable database. It's been here, I think, for the hospital over 15 years. And the challenge with our application was that it didn't provide capability to have a built-in dashboards for staff visibility, and also to kind of review the historical work task needs, resources. So it was no ability to consolidate a lot of our reports information from like the work order manual to our equipment information to our contracts, etc. So and then the other challenge with our application with Ames database was that you couldn't access the application anywhere. You had to actually, it was user and specific to a device. So if my staff members or even myself would have to like log into the application to a computer, I don't know, in Tune West, we weren't able to do that. We had to come downstairs in our biomed shop to access the application, which made it very inefficient. This is what I want to give you guys a quick look what Ames database looks like. This is basically the fields. You have the equipment, the different tabs or fields, equipment information profile. The history log contains the historical work order repair count and information. The PM schedule, which is elaborated here, contains the schedule recurring planned maintenance. Information tab, of course, contains like the software versions, firmware updates, etc. MAC address. The challenge with the Ames application, I do want to say, like I mentioned a second ago, is that if we had to export, basically we had to export reports from Ames, we weren't able to consolidate any of the information. We had to pull them separately from each of these fields and then do the merging consolidation Excel in the back end, which made it very challenging, I think, and time consuming and inefficient, of course. And then the other factor I want to include here is that Ames didn't have a user guide, so there was a lot of technical calls from myself at the beginning, try to understand the application, how the data was correlated to each other, and then try to aim, all right, how do we get that, the information and consolidate it to like improve our work efficiency and work needs, and of course, patient care in this case. Another challenge besides the Ames application that I noticed early on when I joined Washington Hospital, the biomed department, was that our huddles, which were meant to be 15 minutes huddle to kind of review the daily needs and tasks, clinical and internal to the department, what the time would take, it was allocated for 15 minutes, it would take my team members more than they would take, sometimes 3 times as much, because if staff was on the floor addressing customer needs, they had to leave what they were addressing to attend the huddle, come downstairs to basically come to the main hospital, to the MHP building, go to the whiteboard manually with the markers, update the board, take a picture, go back to their workstation in the biomed shops, wait for Outlook to open, and then email those pictures to the team and then join the huddle, which was very inefficient, very time consuming. As I said, what was meant to be this huddle for 15 minutes, it would take 45 minutes or more for the staff members. Additionally to the time, being a challenge in this case, taking a long time. The other challenges that I noticed with the huddles were that the images that the staff was taking wasn't very clear. And the handwriting, I guess I'm a little guilty sometimes of that too, wasn't very clear as well. So it was hard. A lot of times I think we're focusing on trying to understand the information that we're including in the huddles rather than understanding the content and like what we were trying to gather from those huddles. And they posed an immediate need for us to like kind of regroup and say, what do we need to improve immediately? Additionally to, as I said, from the huddles, was the QA analytics and reporting from Ames wasn't possible. So there was no standardization how we reported the information or data. It was based on the individual preferences with the team leader or the director, and the information, whether it was from the huddle boards or our overall departmental and data analytics, it wasn't able to be actionable because it wasn't real time. And this is a quick image of what the huddle board looked like and how we managed at the beginning. As you can see, the data here, it's very crowded, right? It's disorganized. The reports don't have a specific priority or criticality, how they're posted. They're just posted everywhere on the board. The colors on the board, I asked that question early on, that do not mean anything. They were just preference of the staff member markers I want to use to update the board. So it wasn't helpful much with the previous status, like what was the goal intent? What do you take from that? What information to decipher? And then how do you address the customer needs, of course, for the day? Again, the same reports here, very crowded, disorganized. So I worked with the team in the next few months. Right after my first 90 days, April, I said, all right, we're going to have the first effort we're going to put in is to streamline a lot of the information on our whiteboard or huddles. So we removed a lot of basically the excessive reports that were posted. The feedback to the team was if it's not adding value, it's taken away. So the reports included here were like 4 to 5 maximum, and it was like anything that would touch the daily, weekly, or monthly reports that were essential in all of those factors. And then additionally, we put a kind of a indicator to the information that was written there that it had to be 2 colors. One is important, essential, one was other, everything else. But still, even though we improve this effort to streamline and make it much more, a little bit improve our communication organization, it really add value because it was still time consuming for staff to walk from one building to another, go back and then share this information. So I reached out to other departments to kind of find out what other departments were doing, how they were conducting their huddles. And IAS informed us, information security, informed us that they were using a digital version of the huddles. And I was very thrilled when I heard that. So we got the copy of their, template and we revised it to make it our own. And as of April 18, we went live with, it was a Friday, but we went live with our huddle board, digital huddle board. And we made it, as I said, our own. We revised it to make it, specific to biomed, make it engaging, how we felt for that day, the information, and keeping the same content was required on the huddles, right? The staff members' attendance, same thing for reminders and announcements. We did include in our huddles some reporting, because that was missing. Again, the information was just printouts. We included some electronic version of the reporting for work order productivity, for corrective maintenance and preventive maintenance. However, there was a challenge with the current here with the report because we basically work with IAS to build these Excel queries to export and merge the data from the work order tables fields to the equipment fields. But the challenge with Excel query was that you had to update the tables in Excel first before they could be updated on the digital huddle board. So even though the process was improved, it wasn't. I didn't see this with the team as a final product because it was very time consuming, even like a few minutes to update the graphs before we could update, in Excel before we could update the graph on our huddle board. So we reached out to IAS one more time, seeking for additional collaboration to improve our reporting and data analytics. And this is where we built our biomed dashboard, which I'll elaborate a little bit. Our huddle boards, we kept it to 2 pages maximum. So the first table, again, the team, the kind of this specific criteria, the high visibility issues at the top. You have primary, the impact of the department, who is the POC for the biomed staff members. And then also we included the field for the MIDAS. So if we had patient incidents, we included the MIDAS number there as a reference. So if staff had questions, we can refer to it. Access the information readily available within 2 minutes or less, and respond to the clinical staff within 2 minutes or less, instead of spending 15 minutes or more to address the need, the customer need or demand. And then the second table included the action log items that may, important to clinical need, but it wasn't direct impact for the day. It may be whether for the week or for the month. And then we also included 6 to 8 projects, a quick summary, as well as some AIMS links I was able to find through tech support, some guidance the staff wasn't aware of actually before. So one thing that, was important for me and my team when we built the work with IAS to build the SharePoint site was that we needed to make sure the information was transparent and senior leadership also had access to the information. I do believe transparency is important. It's how you get buy-in, trust, and collaboration. And it also improves the communication both ways, from the department to the leadership, executive leadership, and vice versa. Before I continue to dive into the SharePoint, our biomed SharePoint dashboard, I want to give a shout out to 2 staff members in IAS that helped us build our vision, biomed vision, to life with this dashboard. And it's Gurjit Kaur and Madhav Bhatt. They did a phenomenal job, very patient to help us, no, I want this graph, we don't want this. So very patient to help us tailor the dashboard to how we want it to look like. This is our phase 1 or a biomed monthly performance dashboard. It includes basic consolidated data for our work order productivity as well as equipment information. The field controls, the fields or input controls to the left side of the dashboard, include the type of work orders. This is a risk factor for the device, the location where the device is included, where it is found, as well as the primary tech assigned for biomed and secondary tech assigned. To the right of the dashboard SharePoint side, we have the quick visual indication, whether it's for biomed staff or leadership. They can interpret and decipher the monthly stats within, as I said, 2 minutes or less, very quick and efficient. The tables with the count included below the graphs, it's a quick count to see, okay, what does the percentage mean? How does it divide it based on the work count of the, for the month? And then another cool feature that IAS helped us build with this is that we could click on each of these digits, 367, each of these digits on the tables, and then it will give a detailed information on the summary table below, from the work order number to the tag number to the equipment type, model, and then location. And then there's a work order note field actually here that's as staff updates his work order or notes, they can display real time. We have within the SharePoint side, we have two tabs or two different tabs built in. So the first one is the current month stats, and the second one is the year-to-date stats that we also we requested IS to help us build. And same input controls or fields, and then the same standard as well for the graphs at the top, summary table with a count, and then detailed table for for anybody, whether it's with leadership or biomed, to review and update clinicians accordingly. And one key that I want to see for both of the huddle board, so the biomed huddle board, the digital huddle board, can be accessed through biomed share drive, and the digital SharePoint, a digital dashboard, our biomed dashboard can be accessed through intranet basically page through SharePoint. So both of these different boards basically for biomed are able, we're able to provide real-time information. The data could be updated, quickly and efficiently. It definitely increase our work productivity and also our workflow processes, as well as our communication. As I said, staff could access any of these it's like if they couldn't access AIMS, they could literally, like if I went on the floor and I had a meeting and I needed to step in on a huddle, I could log into any computer, open the link, basically open the Word document, the digital huddle board, and basically complete the 15 minutes meeting instead of spending 30 plus to 40 minutes trying to get the information and be part of the huddles. And then above all, both of these dashboards actually provided ability to go back and review the historical data. I was able actually for the huddle board, I had a question 2 days ago from OR about a mini robot, and we're able to tell them, actually, I was able based on the email question within 2 minutes or less to answer, saying we installed on August 21st of last year because we had the historical data from the digital huddle board. And it would have taken me or my staff at least 15 minutes or more to try to find the information, right, from a year or less than a year ago, but it was very efficient, process. So even though all these, factors are important, I think the overall goal, right, for both of these lean initiatives was to improve our efficiency and the productivity. And in this case, this translates to improving the patient care. So I provided these 3 graphs as a quick visual indication of the work order or unscheduled work repair, aka repair turnaround time from 2021 to 2023. As you can see from 2021, by the way, I apologize. This was an initial error, not error, but it was a comma, like a numerical, and now it's changed to calendar accordingly in our SharePoint site. So ignore that comma here. But what I want to emphasize here is that the turnaround time, basically from 2021 to 2022, as you can see, is not much changes, right? It's still high, over 60 days. Again, to have an equipment, readily or down, not be able to be utilized for patient care for 118 days or 41 days, it's quite excessive. It's quite high. I think in this time and age, efficiency, right, turnaround time equals the patient satisfaction as well. So when we went live to April, we noticed, quite improvement right on our huddle board. And then as you can see, the high steep here on the 2023, the improvement that we've had so far when we're live with our biomed dashboard SharePoint site. Our turnaround time, I do want to emphasize, not included in the graph, but I checked in the morning today for our January 2024, it's actually 8.21 days. Our goal for this year will be 7-day turnaround time for completion. Our February, which are mid-month now, we're mid-month for this, is actually 4.21. So I am very confident we're going to reach that 10 days or less turnaround time for this year. And this is basically why we put all the effort. It was a lot of work in the back end, but this is the added value long term, right? Now, our vision and goal doesn't stop here. This is just a beginning for us. So we have I guess our vision has diverted as well, has expanded as well. So the next goal for us now is we're working with IS to expand our dashboard information included in there by including consolidating information from a McKesson application as well as our AIMS database. And basically doing a lot of merging and consolidation of the data and SQL application in the back end. But the focus is, why are we doing this phase 2 effort? The focus is to basically facilitate and help the hospital and the organization to be more strategic, right? Improve the way we look at medical equipment lifecycle management and the replacement needs. And then with that in mind as well, how do we also improve the cost repairs for those devices? can we consolidate some of the contract where our leases or rental agreements or repair agreement contracts? Can we cut some of the contracts? Can we bring some of the work in-house? So we will be able to do those data analysis and strategic planning, I believe, through this dashboard, through this phase 2 of the, as we include more information about requisition and costs. And I believe I'm very happy actually I'll be very happy when this is finished in June of 2024, but I do believe this will help also the clinical staff as they, in the annual budget planning to obtain some of the historical data. So instead of trying to like build reports and trying to ask, different people to get information for equipment status, the clinical staff can access this information real time, quickly and efficiently, and then address their basically patient care needs. So less time on admin needs and more time focus on patient care. We also want to include the PM data analytics for biomed, because I do want to look at resource utilization and repurposing the resources. So for example, I'm doing data analysis, which months have the higher inspection needs, and then how do we divide the work more evenly throughout the year? Can we shift around or make changes? And then that ties to the project deployments. How does the inspection needs and count ties to our project deployments and installations? And then the last phase 3 of our dashboard goal, the goal for us is to foster, and I think diversity adds value to every organization, and we're diverse the way we read data, we interpret data, we read information. So I want to foster diversity to the department, but also autonomy to my team members, and each of us look at data differently or interpret or write data differently. So I'd like the team to like individualize their own dashboard, how they want to see their work orders, their corrective maintenance assigned to them, or their requisitions. And then they can also get trends. So if, I want to make it more quantity and quality based. So when staff look at the annual review performance, I can be very objective, say, let's look at the progress and completion. And let's be, what recommendation and support I can provide for you throughout the year. So these are some of the efforts for this year for us, and our phase 2 and phase 3. This is our goal, June of this year and December. And that's all I have today.
Full year. Yes. A lot of work.
So I do want to emphasize the cool thing about this phase 2. We already had done a lot of the back work and the baseline for the queries and the back end. So it's just tailoring the dashboard now. So I feel very confident we'll finish by this June timeline for the phase 2.
Good. It's just nice to see the move to the digital dashboards, so the data is up to date and comprehensive.
Gotta feel good. Good job. Good job, Anita.
Thank you.
Thank you. Thanks,
Thank
Anita.
you. Thank you.
Sheila.
We go on to Service League report by Sheila Vijay.
Thank you, Dr. Epen. Good evening, district board members. As the Service League concludes its fiscal year at the end of February, I extend my heartfelt appreciation to each of you for your support and encouragement throughout our journey. Here are a few highlights from the last month. In January, 175 volunteers contributed 2,038 hours. On Tuesday, February 13th, we hosted a successful annual meeting and luncheon. The event not only provided a platform to reflect on our accomplishments, but also fostered unity and camaraderie among the volunteers. Thanks to an increase in our masquerade sale and gift shop revenue, we were thrilled to be able to contribute a $20,000 contribution to the hospital's trauma designation work this year. At the meeting, Service League volunteers elected the following slate of officers for our 2024-25 year. In addition to me serving as president for a second year, the new officers will be Marina Bigon-Gary, first vice president, Jill Zyman, second vice president, Carissa Barberi, treasurer, Marlene Iamura, secretary, and Shri Gamardo, parliamentarian. I'm very grateful to the Service League leaders who have stepped up to serve on the board with me. In the last year, I'm proud of everything our volunteers have achieved. Our collective efforts culminated in a mosaic of services in areas such as nurse unit assist, No One Dies Alone, wolf canine therapy, special care nursery, birthing center, surgery liaison, and many more. Our volunteers have made an enduring impact, fulfilling our mission to serve with dedication and compassion. Looking ahead, I'm excited to share our plans to open the infusion center for volunteering. We are also exploring additional opportunities in the Washington Radiation Oncology Center, Trauma Center, and other areas as needed. In conclusion, I extend a special thanks to Kimberly and the board for your unwavering support and steadfast faith in our volunteers. Additionally, my heartfelt gratitude goes out to every individual within the hospital. Your warm welcome and open arms have not only made our volunteers feel welcomed, but have integrated them into the very fabric of our hospital community. That concludes my presentation. Please let me know if you have any questions.
Thank you, Sheila. Always appreciated you and your team. And
Thank you.
especially yesterday's luncheon was great.
Just the luncheon, Dr. Epen?
Especially your luncheon.
We appreciate the donation to the trauma program. That is very well needed, and it's going to help a lot in our journey to seeing our first patient, hopefully over the summer.
I was just kidding, Dr. Epen, and thank you, Kimberly, and thank you, Dr. Epen.
Thanks. So next, move on to quality report, dialysis annual update.
Yes, I'd like to introduce Dr. Jeannie An. She is the medical director of the acute dialysis services. She has been a community nephrologist in Fremont since 2001. She's medical director, as I mentioned, of Washington's acute dialysis services, and is also medical director of the Vita Fremont Dialysis Unit. She went to college at UC Berkeley and graduated from the University of Illinois at Chicago School of Medicine. She completed her residency at Kaiser Permanente in Oakland and her fellowship at UC Davis in Sacramento. She is married with a daughter and 2 rabbits. I thought you had a different animal at one point, but I guess it's the rabbits now, Dr. An.
Yeah, actually, I've only ever had rabbits.
Okay.
Thank you, everybody. And I appreciate the invitation, and I look forward to spending the next 95 minutes with you explaining our dialysis clinical operation services.
Good one.
Okay. Okay, so next, this is our annual report, and it's on the fiscal year ending in June 2023. Our mission is to serve the community by providing high quality care, clinical excellence, and efficiency in the dialysis department. So we had a different history, but we internalized our dialysis service in August of 2018. We provide services in the modalities of hemodialysis, peritoneal dialysis, and plasmapheresis. There's a tag for locations. I've been told that eventually we're going to move, but as of now, we're located in 3 South in the main building. We provide a 24-hour service 6 days a week. So on Sundays, we provide on-call services only. No routine scheduled treatments should be on Sundays. Next slide. So a little background on what dialysis is. Dialysis is basically a replacement for your kidney function. It's a process in which waste products, salt, extra water, toxins are removed from your body, helps to maintain normal levels of certain electrolytes in your body, such as sodium, potassium, bicarbonate. This is basically what your kidneys do. So the population who needs dialysis in the hospital are patients with acute kidney failure due to overwhelming infection, trauma, or other catastrophic health events, or people who do not have functioning kidneys due to progressive irreversible loss of function from diabetes, high blood pressure, or other chronic illness. Next slide. So hemodialysis is a form of dialysis treatment. Hemodialysis involves cleaning the blood. It removes the blood from your body through a catheter that's inserted into a large vein, goes through the filter machine, and then the treated blood is returned to the patient. Next slide. Peritoneal dialysis accomplishes the same goals, but the toxins are removed from a catheter placed in your abdominal cavity. Sterile fluid is placed into the abdomen. The toxins diffuse into the fluid by natural process, and then the fluid is exchanged, and this is how you remove toxins from your body without the use of blood or needles. Next slide. Plasmapheresis is another service that we provide. This is not dialysis. It's a way of removing plasma from the blood by taking the whole blood, centrifuging it to separate the plasma from the cells, and transfusing the cells back to the patient. So we use this process to treat conditions in which a protein in the plasma, such as immunoglobulin, is toxic to the body. So conditions including neurologic, hematologic, metabolic, rheumatologic, and some kidney diseases, as well as certain intoxications, can be treated with plasmapheresis. Next slide. This is our utilization counts. So our dialysis service is very busy. Our monthly counts range around 220 to 200 or to 300 during the winter time. The majority of the treatments are hemodialysis, as you can see. We have a few peritoneal dialysis. That's what the CAPD notation means, and more rarely have the use for plasmapheresis treatments. Next slide. So patient and staff safety measures include timeout documentation, monitoring hepatitis B surface antigen status, hypotensive events. We also keep track of rapid responses and code blues during dialysis. Our infection control measures include water cultures, LAL levels, hand hygiene, MRSA status, and CLABSI, which is central line associated bloodstream infections. Next slide. So our monthly timeout documentation is excellent. It's at 100%. We have no problems with that. Next slide. Our hepatitis B status. So this is important because the majority of our treatments are hemodialysis, and hepatitis is a bloodborne illness. So we try to ascertain the hepatitis B status prior to the treatment, so we know how to adequately bleach and treat the machine. So our the up and down on this graph looks big, but if you look at the scale, our goal is 10%, and we are consistently in the 1 to 3% for getting the hepatitis B status prior to the treatment. And in June, our percentage was 1.6% of patients' Hep B status was unknown at the time of treatment. Next slide. Code blue events during dialysis. Unfortunately, code blues happen in the hospital, and sometimes they happen at the dialysis unit. I think June was an atypical month for us. Usually we don't have any events, or we have one. Next slide. This is an example of what our water culture reports look like. So the green means that those measurements were within goal. So we have 7 dialysis machines and 7 reverse osmosis machines that are tested monthly. Next slide. Hand hygiene is tracked throughout the entire hospital, but also at the dialysis unit. So for quarter ending June 2023, we were at 96%. Next slide. MRSA surveillance. So we have special population. This was mandated by a state a state bill that said that hospitals had to monitor MRSA infections. And at Washington Hospital, we've chosen the dialysis population. So the MRSA status for all dialysis patients are tested upon admission and also within 24 hours of discharge. So our compliance in June was 87%. This only goes to the end of the fiscal year. I'm happy to say that currently our rates are more in the 94 to 93% from our recent data. Next slide. So during the time of our for fiscal year, we have not had any central line associated infections. Next, it's a boring graph, but good to see. Next slide. We recently obtained the ability to request feedback on patient experience, the courtesy of staff, information, the comfort level, etc. And this data goes to more recently, September of 2023, and you can see that our dialysis staff gets very good feedback for patient experience in the dialysis unit. Next slide. This is a performance improvement plan. We concentrated on decreasing delays in the hospital. So one important thing to do was to define what a delay was, and we decided that would be 45 minutes after the scheduled time. So we we asked our EPIC team to help us track the top 3 reasons for delays, improve communication with the transport teams, unit managers, and food nutritional services for any identified areas of improvement. The food nutritional services are involved because for our first shift patients, or our second shift patients, we request that they get an early breakfast or early lunch in order to avoid delays to their treatments. We audited the delay trends and the delay, as I said, was defined as later than 45 minutes from the scheduled time. So we track these audit findings monthly, and we have ongoing feedback with our transport team, unit manager, and our nutritional services team. Next slide. So patient service initiatives that were started this year, patient education is our continued focus. We are using the SNAP board in order to track the delays. So previously, the nurses would they would chart that it was delayed, but it wasn't really it was just their sense that the treatment was delayed and not really a definition. We had 2 hemodialysis machines that were donated from regional hospital. However, unfortunately, I don't think we're going to be able to include those in our pool of dialysis machines because they had too much maintenance needs. Our ultrafiltration goals are something that we are continuing to monitor, and we're currently meeting those goals. We have a new dialysis manager, Gina Goldstein, and she's great. She's very familiar with staff in the hospital and facilitates communication with the floor staff, and it improves our rounding and our discharge planning as well. Next slide. This is our continuous quality improvement blueprint for fiscal year of 2024, patient education, procedure timeout, compliance with bacterial and endotoxin testing, compliance with chloramine water testing, stat treatment completion, and ongoing focus on hand hygiene. Next slide. The quality blueprint for patient outcomes include the adverse event rate, complications including hypotension, infections of bloodstream infections in particular, patient experience, infection prevention with tracking of our hepatitis status and reduction of our central line bloodstream infections, although it is difficult to go lower than 0, but still our goal. Next slide. Okay, so as I've stated before, our MRSA swab compliance has improved. We're going to continue our CLABSI line performance for dialysis catheters. Now that we have feedback from Press Ganey reports, we can continue to try to see what areas need improvement and monitor patient satisfaction. Next slide. So with regard to continuous education and training, 100% of our staff are trained on plasmapheresis and peritoneal dialysis procedures. There's an annual dialysis specific skills validation. Our dialysis nurses are encouraged to pursue board certification for nephrology nurses. And we have several med-surg nurses who are cross-trained so that if we have higher than expected census and we have a need for staff, we have the ability to float those nurses and take care of our dialysis patients. Next slide. So here's a picture of Gina and some of our staff. You can see our nurses are exceptionally attractive people, and they work hard to provide the best care to our patients. They're compassionate. These are usually some of the most frail patients in our hospital, and they continue to try to do better. Next slide. Next steps. So coordination, medical social worker is always something that we feel it would be a benefit to our patients. Our dialysis patients have one of the highest social needs in terms of transportation, outpatient clinic placement, mental health needs, medication coverage, housing issues. And the social worker is important in establishing any community resources for when our patients leave the hospital. Next slide. I believe that's it. If you have any questions, please feel free to ask Dr. Nicholson. I'm sure he'll be able to tell you what's going on.
Jeannie, I have a question for you. Does your report include the CRRT treatments in the ICU, or does that fall under a different domain?
Yeah, that's an intensive care procedure and doesn't involve our dialysis nurses at all. So those treatments are not included in this report.
Thank you.
The only question I had is there a backlog? Is it easy to get an appointment?
A dialysis appointment? Or what do you mean?
Is there a long wait? Is there a long wait to get an appointment?
So that really depends on the hospital census. So our, every day or every night, we have a list of anticipated patient treatments, and we prioritize discharges, and we prioritize patients that are not clinically stable. So if the intensivists say that patients should be dialyzed early in the morning because they want to extubate the patient, then we take that into account when we are putting our schedule together. Add-ons, if they're stable, tend to be later in the day. So unlike a chronic dialysis unit, the schedule is very fluid and changes on the composition of our census. Does that answer your question? But if you needed dialysis, Dr. Epen, we would put you first shift.
I hope not. Thanks.
Thank you very much.
Thank you.
Okay, thank you.
Happy Valentine's Day.
let's move on to the finance report. John.
I will be presenting the final numbers for December, which improved slightly from the preliminary numbers that the board saw last. December 23, we saw increased volume at the hospital and in the outpatient. So inpatient average daily census was 175.8 on a budget of 176.4. The combined average daily census was 185.6, which was pretty much on budget at 185.7. Discharges trailed a little bit by about 104 or 10% of budget. And year to date, they're off just under that, about 9%. Patient days for the month of December were 5,449 on a budget of 5,468. So again, just under at 19 days. Observation equivalent days, were 304 on a budget of 287. Here, a bigger number is not necessarily a better number. So we're off by about 17. That observation equivalent days year to date were off by 524 through December. The average length of stay increased in the month of December at 571 on a budget of 520, or off 51 basis points. And year to date, we're just over the budget at 534, or 11 basis points. Acuity for the month of December did increase over prior months. The case mix index at 1.598 was higher than the budget of 1.546 by just over 5 basis points. And year to date, our actual versus budget case mix index is better by 2.3 basis points, or 0.023%. Deliveries for the month of December were over budget by 7 at 136. Year to date, we do trail our year to date number by 35, or just under 5%. Surgical cases exceeded budget by 1, with 490 on a budget of 489, and year to date, they exceed the budget by 3. Cath lab cases trailed again in December at 146 on a budget of 210, or 64 cases. And then year to date, we're at 976 on a budget of 1166, or about 190 over the first 6 months. Outpatient visits were 8,054 on a budget of 8,314, or 260, which is just over 3%. And year to date, we're tracking pretty close to budget on outpatient visits, off 27. Emergency visits, 5,254, were just under budget by 143, or just about 2%, at 5,397, and we're off about 791, or 2.6% year to date on ED visits. Breakdown for the surgical cases in the month of December. Ortho cases were over budget by 13 at 206 on a budget of 193. And then the other one that was over budget was cardiac surgical with 16 on a budget of 13. And then you can see vascular and endoscopy trailed by 4 cases over their budget. And year to date, the neuro, the cardiac, and the vascular cases are trailing year to date by a combined 44 cases. Cath labs for the month of December at 146 on a budget of 210, which is about 30% off at 64. And you can see the 2 large contributors here were the peripheral vascular and the non-vascular. Peripheral was at 25 on a budget of 54. And non-vascular was 39 cases on a budget of 65. Neurointerventional radiology, we had budgeted of 2, and we had 2. So, hit their budget. Operating indicators, productivity, Productive FTEs for the month of December were 1,518.1 on a budget of 1,499.2, or 18.9 to the negative. And then non-productive FTEs at 173 on a budget of 221 were 48 under the budget for non-productive. Total FTEs at 1,691.1 on a total budget of 1,720.2, or 29.1 better than budget. Total FTEs per adjusted occupied bed were 577 on a budget of 6.29, or 52 basis points better than budget. A lower number on the actual is better than a higher number there. And then year-to-date, we're at 605 on a budget year-to-date of 6.3, or 25 basis points better. Summary of total deductions. We had a gross revenue of $215.664 million on a budget of $213,717, or about a $2 million difference. Contractual allowance was $160,312,000 on a budget of $159,502, or roughly just under $1 million different. And so contractual as a percentage of revenue was 74.33 on a budget of 74.63. Year-to-date, though, on contractual, we are still slightly higher than budget at 0.08 basis points, or excuse me, 0.08%. Provision for bad debt. This is a reflection of the following, the line right below it, which is provision as percent of revenue, that you can see the 2.09. So you can see the number was 4.493 for the provision of bad debt, which is over the budget, which was based on a budgeted number of 1.82, 3.891 million, or 602,000. So the total deduction was 164,805 on a budget of 163,393, which is 1.412 million higher than budget. But the number for total deduction came in at 76.42 for December on a budget of 76.45. Now we get into the GASB income statement, summarized income statement. Again, we have the gross revenue. As a reminder, 164,805 was the total deduction from that. And so that left us with a net operating income of 51.659 on a budget of 51,768, or a miss by 0.2% on the net operating revenue. Operating expenses came in at 48.835 million on a budget of 48.973, or $138,000 to the positive. And then our net operating income is 2.824 on a budget of 2.795, or $29,000 to the positive, which makes our net operating margin 5.5% actual on a budget of 5.4. Then we have the GASB recognized expenses. And when we get down to the bottom, under the non-operating income or loss line, you can see that we are recognizing 2.215 under GASB as a gain for those non-op areas on a budget of negative 33,000. So we're positive 2.248 million. And then bringing our total net income, so we're taking the net operating income and we're adding the non-operating income together. Our net income is now 5.039 million on a budget of 2.762 for a gain or variance of 2.277 million. Year to date, we still trail our budget. We have net income of a negative 2.06 million on a budget of a positive 4.06 million. So we're off just over $6 million year to date on net income. The net income margins, though, have strengthened as a result of the overall performance. 9.8% for the month of December on a budget of 5.3, and an increase of fiscal year to date
to negative 0.7 on a budget of positive 1.4. So now these are the same. This is the same report, but as a reminder, we take out the interest expenses, the property tax revenue, and the unrealized gain for the FASB results. And I won't go through. What I will point out is on the net operating margin, you can see the numbers are slightly smaller because we took out some of those gains, some losses, but most of the gains. And then at the bottom, you can also see the 2.75 is our net income as opposed to the prior slide where we had 5 million. So we took out that unrealized gain loss, which added just over $2 million. And then you can see that our year-to-date is negative 7.6 on a budget of 2.6 positive, bringing us negative on a FASB basis to negative 10,259,000. So, and then my last slide is the GASB EBITDA. And again, without being too repetitive, we take the net operating revenue and we remove the operating expenses except for the depreciation, which is included in the prior number. So we have 51,659,000 in net operating revenue, 45,394,000 in the operating expenses excluding depreciation, for an EBITDA of 6.265 million on a budget of 5.832, or a gain of an excess of 433,000. And then our EBITDA margin here is 12.1 on a budget of 11.3. So we are creating cash flow for the organization. And then on an actual basis, year to date, we're at 11.718 million on a budget of 23.4 million, for 3 million, for a difference of 11,712,000 is negative. And then the net operating margin, you can see the 5.5 on a percent on a budget of 5.4%. And then finally, repeating the numbers from the earlier slide, the GASB slide, 5 million on net income on a budget of 2.762, bringing our variance or positive gain to 2.277, or 9.8 and 5.3% for the actual versus budget. And I'll stop there.
All right, thanks. Thank you. So we go on to the hospital operation report.
Yes, so I will present, thank you, Dr. Eben, the preliminary numbers for January of 2024. So beginning with gross revenue, patient gross revenue of $216.2 million for January was favorable to budget by $10.6 million or 5.2%, and higher than January of 2023 by $16.9 million or 8.5%. As you can see on the graph, inpatient gross revenue of $127.8 million was favorable to budget by $1.7 million or 1.4%. And outpatient gross revenue of $88.3 million was favorable to budget by $8.9 million or 11.2%. Moving on to the key statistics, the average length of stay of 5.45 was unfavorable to the budget of 5.23 by 0.22 or 4.2%, and was also lower than the January of 2023 of 5.86 or by 7%. I do want to just say in January, there were 15 adult discharges with lengths of stay greater than 30 days, ranging from 31 to 101, and excluding those long lengths of stay, we were at 4.81. However, we still do have 7 patients with lengths of stay over 30 days, and they range from 31 up to 128. As you can see, then moving on to our outpatient observation equivalent days at 304, seems to be exactly what we saw in December, that were unfavorable to budget of 281 by 23 or 8.2%. Our inpatient average daily census of 165.6 was favorable to budget of 161.2 by 4.4 or 2.7%, but lower than January of 2023 average daily census of 165.8. Then the combined average daily census of 175.4 was favorable to budget of 170.3 by 5.1 or 3%. It was also higher by 0.9% than January 2020 average daily census. Looking at our discharge trends, discharges of 948 were unfavorable to budget by 955 by 7 or 0.7%. January of 2024 discharges were 5.1% more than January of 2023, and really it's mainly driven by the surgical volume that you'll see down below budget. Looking at our patient day trends, patient days of 5,134 were favorable to budget of 4,998 by 136 days or 2.7%. And patient days were 7 days fewer than January of 2023. We did see our ICU days that were favorable to budget by 9.3%. Telemetry days were favorable to budget by 10.9%. And also, it should be noted, given our high census, we did open 3 West and had about 40 patient days there. We've been opening 3 West in terms of trying to decompress our emergency room. So I know that the team, the clinical team, and everyone's been working hard to ensure that we're getting patients into the right level of care. Looking at our surgical trend, total surgeries in January at 468 were 24 or 4.9% unfavorable to the budget of 492. Inpatient surgeries at 200 were unfavorable to budget by 13 or 6.1%. Outpatient surgeries at 268 were unfavorable to budget by 11 or 3.9%. Going on to looking at the breakdown of the surgical activity, our orthopedic cases were right on budget. I will say that Dr. Saw has started doing more of some of his orthopedic cases over at the Washington Outpatient Surgery Center, and this month he did take 17 cases over there. Our neurosurgical cases were below budget by 2. You can see our vascular surgery, endoscopy, and other surgery were all under budget, but our cardiac surgery was over budget by 3 cases. Moving on to our cath lab trend, we have been seeing and did see in this month in January an increase in our cath lab cases. They came in at 191, but they were still 16 or 7.7% unfavorable to the budget of 207, but were 36 or 23.2% more than January of 2023. Our cath lab inpatient cases at 102 were 13.6% unfavorable to the budget, and outpatient cath lab cases at 89 were consistent with the budget. Moving on, you can see in terms of the breakdown, and as you heard from from Dr. Agarwal, we are seeing more cardiac cath related cases in the cath lab. We're still below budget though with non-vascular IR cases and peripheral vascular cases. So you can see the total of 191 is 7.7% less than the budget, but greater than January of 2023. Looking at our deliveries, they came in at 124 for January. That was favorable to budget by 18 or 17%, and were 23 or 22.8% more than January of 2023. Our C-section rate at 35 was 28.2% of our total deliveries, which was 3.5% higher than the budget of 21.7 total deliveries. In terms of year-to-date, we have 881 deliveries, and we're unfavorable year-to-date by about 17 deliveries or 1.9%. Looking at our non-ER outpatient trends, came in at 8,955 visits, were favorable to budget by 226 or 2.6%, and also more than January of 2023 by 6.7%. Primarily driven, our imaging services have been very busy over the last few months, followed also by diabetes education and EKG visits, and that was offset by lab visits that were unfavorable to budget. Moving on to our emergency room visit trends, as you can see, we've continued to have high visits. They came in at 5,210. However, they were unfavorable to our budget by 176 or 3.3%, but we're 10% more than the prior year. So we're seeing more, but and especially over the last 2 months, as you can see with what we've been, the last 2 months have been very busy. Just slightly below budget. Looking at our gross revenue recap, surgical revenue was unfavorable to budget by $2.5 million or 6.2%. If you remember, cases, and it tracks with cases that were unfavorable to budget by 6.6%. Cath lab revenue was $393,000 unfavorable to budget or 3.2%. And as mentioned, cases were unfavorable to budget by 16 or 7.7%. Room and board was favorable to budget by $1.8 million, and also patient days were favorable to budget by 2.7%. Delivery revenue was favorable to budget by 35.3%. As mentioned, we did have a higher C-section rate that was also driving that, was helping to drive that increase. Emergency revenue was favorable to budget by $548,000 or 4%. And lastly, as you can see, ancillary revenue was favorable to budget by $10.2 million or 10.9%, which was driven by our higher outpatient revenue. So we had a challenging payer mix for the month, even though we were very busy. You can see that government-sponsored patient revenue made up 75.8% of the total gross revenue. This was unfavorable to the budget of 72.6% and higher than the prior year's percentage of 74.1%. HMO gross revenue was 1.5% of total gross revenue, unfavorable to the budget of 2.2%. It was also lower than the prior year's percentage at 2.7%. I do just want to note that some of this is due to some of the financial class changes from HMO to a government Medicare sponsored, such as we've been seeing more of TRICARE, like Veterans Administration sponsored plans that more align basically with our Medicare rates in terms of that and falls under that. Our PPO gross revenue of 21.8% of total gross revenue was unfavorable to budget of 23.7%, and the payer mix was higher than the prior year's percentage of 21.7%, just barely there. Also, benefit of private pay gross revenue was 0.9%, favorable to the budget of 1.4%. There was a total of $935,000 in charges from out-of-country patients. Moving on to productivity indicators, I do want to note that for the pay period in January, it included both the Christmas and New Year's holidays, so you can see that our non-productive time was very high compared to the budget. So productive FTEs were favorable to budget by 103.5 or 7% at 1,366.6. And non-productive FTEs were unfavorable to budget by 72 or 35.3% at 275.9. Total FTEs, 1,642.5 were favorable to budget by 31.5 or 1.9%. And then total FTEs per adjusted occupied bed came in at 5.87, which were favorable to the budget of 6.37 by 7.8% or 0.5. And less than the prior year, which was at 5.97. So overall, with that, looking at our preliminary outpatient statistics, our witness clinic visits did come in at 16,844, which were unfavorable to budget by 13.4%. And basically both in the primary care and pediatrics, that was mainly due to two things. First, again, in terms of both having a great deal of time off, both due to Christmas and the New Year's, but also we have a number of open positions in both primary care and in specialty care. So really have seen, we had thought that we would have some of these positions filled, also had, that is something that, as you know, we have been, our new chief medical officer and others are working hard to recruit new physicians. Moving on to our preliminary, our radiation oncology center statistics, as you can see, radiation oncology center treatments were 22 or 4.7% below budget at 451. There were 23 new patients referred, which were 2 higher than the fiscal year average of 21. And there were 22 new treatment starts, which were 2.4 higher than fiscal year 23 average of 19.6. If you want to go to the next slide, we've been just in terms of looking at, as I mentioned in the past, that the number of treatments per patient have been reducing, just given the more precise that we are with being able to, with our treatments. And so just to look at some of the trending, and as you can see on the left in terms of, and this represents 2019 through 2023, and looking at the number of referrals to the radiation oncology centers, is the bar graphs on the far left, in the middle, new consults, and then new starts. So as you can see, the radiation oncology number of referrals have decreased. However, we've really worked in terms of looking at the referral criteria. And as you can see with the new starts, that means the number of patients that are being referred, that percentage that are coming now, even though they're less, there's 93% that are being treated there. So we're seeing the new consults increase, the new starts are increasing, and those who are actually getting treated, the number has increased too. So I just think this is starting to give a better picture of sort of where we stand with radiation oncology. Moving on to our Development Corporation, our outpatient statistics. Development Corporation came in at 2,160, which was unfavorable to budget by 110 or 4.8% for January. And this was really driven by our outpatient rehab center, which was unfavorable to budget by 185 or 10.9%. And again, we had a number of, a couple of staff that were on long extended leave and time off, and that definitely impacted our volume. The surgery center, Washington Outpatient Surgery Center, was above budget by 7.7%. The surgery center cases were also above budget by 20.6%. So it was really driven by Washington Outpatient Rehab Center. We've seen that when we're not fully staffed over there. Looking at our key financial statistics, as you can see, days cash on hand for January ended at 129 days, an increase of 3 days from prior month. This is really mainly due to our operating cash increase, $3.5 million from collections, which represent 2.3 days. I do just want to recognize our revenue cycle team. They've been really working hard in terms of our collections and really following up. So I do want to recognize what they've been doing and working on their processes. As you can also see, our days in accounts receivable, again, went down to 58.1, which is less than, if you can see, in December was at 62. So again, revenue cycle and many others have been really focusing on this. And our charity care adjustments were $282,000 in January of 2024. So those were the statistics for January. Busy month, but some challenges there too. Yeah. So.
Be helpful if we could cancel them all.
We have probably other people that were not wanting to come to work or something too. So.
Thanks, Kimberly.
So I'll go on to the next piece. I want to start with the Employee of the Month for February of 2024. It's my pleasure to introduce Catherine, or Katie Rikers from EEG. She was born at Washington Hospital, and her mother worked here for more than 30 years. Katie's compassionate nature led her to a master's degree in counseling psychology. She had planned to pursue a career as a therapist, and she had started her clinical hours in 2009 as an unpaid intern and needed to, at the same time, earn a living. So she accepted a position at the hospital's Food and Nutrition Services Department, where she worked for 3.5 years and then enrolled in a training program to become an EEG technologist. So in November of 2013, she earned her neurodiagnostic technician certificate. And the following January, she was hired as a full-time EEG technologist. and she realized she found her calling.
Nice.
So it was wonderful. She's successfully completed her transcranial Doppler training, and in September of 2014, she passed a rigorous examination and became a registered EEG technologist. As a member of the EEG department, she receives requests from neurologists to provide EEG tests at the bedside to patients. These patients may have varying reasons for requiring these tests, and they may and had a stroke or an accident or some type of incident that needs this type of testing. And they all have one thing in common. They are worried, uncomfortable, and probably scared. And she always remembers that each patient is a person first and a patient second. She knows that each patient has a story and different healing needs, and is aware that all need comfort and empathy, in which she strives to provide. Her manager, the Director of Rehab Services and Occupational Therapy, Christy Casey, describes Katie as a strong team player who maintains relationships with her coworkers and the neurologist to be able to troubleshoot any issues that may arise. She's an excellent mentor to new technologists. And her coworkers describe Katie as a joy to work with and someone with a positive outlook and strong work ethic. She lives in Pleasanton, enjoys swimming, paddleboarding, and hiking, raised her 2 children, Aiden and Haley, and enjoys walking with her dog. So congratulations, and she truly really emphasizes and lives the patient-first ethic. So. All right. Moving on to our health promotion and outreach events in our community. We've been busy in January and coming up. So January 11th, Dr. Lynn, Family Medicine at the Medical Foundation, talked about cervical health. Why is it important? Did that on Facebook Live and YouTube, and you can see the number of views and non-live views. We also had Dr. Wayland from Emergency Medicine doing a very important topic on naloxone and a lifesaver in the opioid crisis, and really had on Facebook Live and YouTube 68 live views and 407 non-live. Dr. Liu, our vascular surgeon, talked about leg pain and wound care at one of our senior centers, and then we also Washington hosted the Union City Health Summit. Angus Cochran and Kayla Gupta presented the community needs assessment. As you remember, there are a number of areas that they want to focus on in Union City, and this was sort of that first step to talking more about partnerships around improving health. February 3rd, Washington hosted a tattoo removal clinic, and 24 residents were served. On February 6th, we hosted the 4th grade students from Rise Academy. You can see a number of our physicians participated in this, especially our trauma director, Elwood Conaway, talked about Stop the Bleed and really educated those 4th graders. I know he was very excited to be involved in that, and he said that he talked for quite some time with them about it. So, and 25 students and teachers attended. February 7th, Tammy Tyson, our Director of Oncology, and Christine Mickelson, our Women's Center Coordinator, talked about breast cancer prevention and early detection and treatment. Again, one of our senior living communities. February 10th, and I will talk a little bit more about it, that we had a very successful Advances in Neurosciences, our 10th Bay Area Symposium, and we had over 140 people attended that. February 13th, yesterday, Dr. Mark Saleh, our urologist, talked about aquablation, and you can see in terms of how many live views he had and how many those that have watched subsequently. So that's a very popular topic. And again, yesterday, Union City, Angus Cochran presented to the Union City Council meeting the community health assessment. See some of the pictures of some of the events that we did. Our 4th graders there. See that? And then just talk a minute about, I just want to, again, recognize and thank Dr. Sandeep Kumar and Dr. Eldon Eichbaum. They moderated the symposium. I also want to just mention that Dr. Desmond Erasmus was honored with the Moses Tagioff MD Neurosciences Award for his dedication to quality, excellence, and patient-centered care in neurosciences. And I think we all truly believe that he has really made a huge impact in neurosciences for this healthcare system. Unfortunately, he was not able to be there, but his wife and daughter accepted the award on his behalf. Also, just want to say that I want to thank everybody that was involved. It really took many different areas and people who helped to make this a big success. And I know everything, marketing, communications, and many other people did too in terms of the Medical Foundation and others. So thank them. And you can see on the next slide, we had a really great lineup of speakers. We had many of our own speakers who spoke about very important topics, and we did have some outside speakers from UCSF and University of Washington. So I believe we have taped it, and it will be available in terms of seeing that. So I recommend, again, those of you who weren't able to attend to listen to some of the talks. Moving on to some of the upcoming ones, as you can see on today, Dr. Joyce Liu is talking again about leg pain and wound care. On February 20th, Dr. Rajiv Saigal is talking about scoliosis and spine deformity. 29th of February, Dr. Nord, arthritis and joint pain at one of our senior living communities. And then on February 29th, in partnership with Haller's Pharmacy, we're going to be talking about Save a Life from Opioid Overdose, an important, again, topic for our community's health. Moving on to a couple in March, you can see Dr. Srivatsa, one of our gastroenterology physicians, is going to be talking about colorectal cancer. March 13th, J.B. Goodyear is going to be speaking about mental health and grieving. And lastly, Betty Goodwin, who's one of our RNs in the clinical nurse specialist in the ED, is going to be talking about choking awareness. And we're going to be talking more about this about this day and the work that we're going to be doing in terms of educating our community. So very excited about this. I'm really focusing on restaurants too. All right, just briefly, on February 29th, the foundation will hold another free charitable giving and estate planning seminar. Just a reminder, our 37th annual golf and bocce tournament will be held on May 2nd at the club at Castlewood. We had a very successful annual meeting for the Charitable Foundation on January 30th. The healthcare system received over $2 million, so we're very excited for that. A lot of it is going to our oncology program and the build out of that cancer center. And we also, on February 2nd, received $21,500 from the Mission San Jose Rotary Club that is going to support our trauma education for nurses. Two more things. I just am very excited. Many of you have heard about the spines that we were accredited through Joint Commission, received the certification in spine surgery that was awarded to us. And we're only one of 20 hospitals nationally to attain this. And so we're very excited and really represents the quality of our spine program. And then lastly, we have two other recognitions from Healthgrades. And Healthgrades is one of the leading resource consumers use to find a hospital or a doctor. And we have been recognized as one of America's 50 best hospitals for outpatient orthopedic surgery that's really focused on back and neck surgery. And then the second one is we're one of America's 50 best hospitals for outpatient joint replacement. So really want to congratulate the staff and everybody, including our neurosurgeons and joint replacement surgeons on this. So, and I know that was my report. So thank you very much.
Thank you. So moving on, we do have one more action left. Item B, the motion approval pension plan amendment. Director,
I'd like to just say a few words about that before we go any further. I think that you saw from our financials today, yes, we had some improvement, but we are still not meeting our overall financial metrics. And this is a same issue that many hospitals in the state are facing. We're seen a lot of challenges, even though volume's improving, but it's really being offset by increases in our labor costs, inflation, and as you can see, sort of that shift in the payer mix to more government sponsored, and unfortunately that's lower reimbursement. We are focusing on really taking steps to improve this situation, and there's not one sort of initiative or work that needs to get done, and I really see it in 3 areas, and that's pursuing growth and increasing revenue. It's looking at those new programs. We talked about our cardiothoracic, we've talked about urology and others, but really looking at pursuing growth and increasing our revenue. It's also looking at improving our efficiency, and that's really important, looking at our length of stay, our observation, work that we're doing on our revenue cycle. You've seen some improvements there too. So all of that's important. And then the last piece is really looking at our cost structure and, looking at relationships with our vendors, looking at ways that we can decrease that, and we've taken some steps already in that direction. But it also has to be noted that labor is one of the largest components of our expenses. And, we've worked in many ways in terms of improving our productivity and looking at other ways to do that. But we've got to continue to focus on in reducing that expense. And so really what we're wanting to do next is this next phase, and that is an initiative of an early retirement program. This is a voluntary program that we've actually done in the past too, and it's really just focused on selected positions. And so I am recommending this evening that the board approve moving forward with this one-time amendment to our pension plan, so that it does, it's focused on individuals that are at least 55 years of age and have at least 5 years of service, and also meet other, criteria in terms of those positions and their selected positions. And so it does provide an additional 5 years of improvement for those who would be retiring at this time. So again, it's a one-time plan amendment to help to support this early retirement program. Mm-hmm. Any other?
President, in accordance with the recommendation from the Chief Executive Officer as described in her memo dated February 14, 2024, I hereby move that the Board of Directors authorize the Chief Executive Officer to execute Amendment Number 8 to the Washington Township Healthcare District Retirement Plan.
Thank you. Second.
The roll call. Director Eapen?
Aye.
Director Wallace? Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Thank you.
So now we have a closed session.
We do have a closed session.
We're now going to close session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make the announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you, and the board will now adjourn to a closed session.